Okay, I will start the presentation. Respected seniors and dear colleagues, on behalf of International Society of Manual Small Incision Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra Chapter, welcome you, all the delegates, speakers, discussant on this wonderful series of webinar that is A to Z of Manual Small Incision Cataract Surgery. Anterior capsular opening is a gateway to successful cataract surgery. The topic is very important. It cannot be completed in one episode. So to give full justice to the topic, I have divided it into two episodes. And today is episode 11, part 2. The aim of our webinar is to popularize smart SICS. It should be safe, cost effective with minimum learning curve, and it should be useful for community basis. We all know that a well-centered and a perfectly sized axis set the stage for a predictable and successful outcome. The quality of axis determines the ease and the safety of cataract surgery. Precision in capsular axis creation leads to enhanced refractive outcome and reduces post-operative complications. Capsular axis is just not a step in cataract surgery, it is a critical skill that impacts patient's vision and satisfaction. This is the basic picture of can opener capsulotomy and capsular axis. And to this important topic, we have chairperson Dr. Prakash Marathi, Dr. Barun K. Naik, Dr. Mandar Paranspe. So for this very important topic, that is anterior capsular opening, do or die, we have speakers who are expert in their field with the best of their knowledge and experience. Dr. Shirish Thorat, Dr. Deepak Megur, Dr. Rajendra Prasad, Dr. Ramesh Shisha, and Dr. Kamal B. Kapoor. And for this topic, we have discussant who will argue, debate and dialogue. Dr. Debashish Bhattacharya, Dr. Yogesh Shah, Dr. Jatinder Bali, Dr. Professor MD Mizanur Rahman from Bangladesh. I am really thankful to all the speakers and discussant for giving their expert opinion, knowledge, and sparing their valuable time and making this webinar a grand success. Thank you. Thank you very much. I will hand over to Ameya Kulkarni for further. Ameya.
Yeah. Thank you, sir. At the outset, I would like to welcome all of you, all the experts in the field and the audience to this webinar of anterior capsular opening do or die. We had a fantastic part 1 last month where we had very spirited discussions on CCC for close to 90 minutes. And I'm sure we'll be having the same again today. So at the outset, I would like to welcome all of you. And I would also like Dr. Sahu sir to give his thoughts on this meeting today. Dr. Sahu, please unmute yourself, sir.
Can you hear me?
Yes, sir.
Yeah. See, as I told earlier that Dr. Anil and you yourself, all of you are doing a wonderful job. And this is going to be set an example for other chapters to emulate. And so definitely the speaker you have chosen are best in their field. So we will be benefiting by their experience, from their experience. So thank you.
Thank you, sir. That was our founder chairman. I would now like to call upon Dr. Buramani sir, if he has joined, who's our executive chairman, to give his thoughts on this.
Yeah, thank you, Dr. Amey. You can hear me?
Yes, sir.
Yeah, it's a wonderful series going on in Maharashtra chapter of ISM SICS.
under the guidance of Dr. Anil Shah and yourself and the entire team doing fantastic job. Each and every topic is dissected thoroughly in every episode. So without wasting much time, I request you to proceed with the proceedings.
Thank you, sir. I don't think Dr. Parikshit has joined. Once he joins, we'll welcome him too.
Satanshu is there?
Yes.
Yes, sir.
So, Dr. Shatanshu, sir, please go ahead with your thoughts.
Thank you, Ame. I welcome my old friends Rajendra and Kamal Kapoor on this platform. The rest of all, we are meeting again and again. I welcome Dr. Rahman sir from Bangladesh. So rest of all, we are meeting Jape Maggie or others. We are meeting regularly on this platform. Dr. Rajendra, you will like that this platform is not promoting SICS, but we are just want to people let know that what SICS magic is. So we welcome both of our new speakers on this platform. And congratulations to Dr. Prakash Marathe and Dr. Anil Shah for showing path to all the chapters. How can they proceed? Thank you, sir.
Thank you, Dr. Satanshu, for your nice words and good evening. Nice to see you here after a long time. Thank you very much.
Thank you, sir. I would now like to call upon our very own Dr. Prakash Marathe, sir, to give his 2 words of wisdom.
Good evening, everyone. As chairman of Maharashtra chapter, I welcome all the speakers, chairpersons, discussants, and participants. Basically, I must thank Chairman Dr. Sahu sir, Dr. Boramani, Dr. Satanshu Mathur, and each and everyone from ISMSS. I think Maharashtra chapter is the most vibrant chapter in the country in today's scenario, I must say. Because when the presidentship was handed over to Dr. Anil Shah, I think he has designed this particular webinar series in such a way that it is almost the syllabus of SICS. And you can definitely refer all the chapters in the country as well as internationally, how the ISMSIS is taking efforts to spread this word of SICS everywhere in the world. And each and every point of SICS has been referred carefully while designing this particular syllabus. And I think interest is getting developed every time, each month, that new topic is being discussed. And when you feel that there is no new topic, I think new presenters, new videos, new speakers are there. And they are sharing their knowledge, and it is getting benefited by each and everyone, all the participants by all these webinar series. So I wish all the success to today's episode also. There are wonderful chairpersons and presenters. Definitely, it will be very nice webinar today. Thank you so much for the opportunity to say a few words. Over to you, Dr. Ameya.
Yeah. Thank you, sir. I would like to go ahead with introducing the short CVs of all the stars that we have here today. So I'll be doing that in conjunction with Dr. Pankaj Shah. Is my screen visible?
Yes.
Yes.
Yes, visible, Ame.
So I would start with the introduction of Dr. Rajendra Prasad. He needs absolutely no introduction. So right now he's the founder director, RPI Institute and Research Center, Delhi. He's the president of DOS. He's also chairman scientific committee, DOS. He has numerous publications and scientific awards and innovation awards to his name. We have Dr. Anil Shah, who's also an innovator. So I think the wavelength matches there. He also has had IRRSI Gold Award in 2017, the UP SOS Gold Award in 2017, the UK SOS Gold in 2017, and the Ecoin Gold in 2020. So, welcome, sir. Next, we have Dr. Shirish Thorat, who's a practicing ophthalmologist for the past 25 years. He's right now the president of the Vidarbha Ophthalmic Society, and he's also the president-elect of the Maharashtra Ophthalmological Society. We have Dr. Ramesh C. Shah. We fondly call him Dr. RC. So he's practicing in Mumbai for the last 30 years. He's passed from KM Hospital in 85. He has been the largest users of multifocals in our country, 17,000 and more. He's pioneer in placing iris claw oil behind iris and trained many surgeons for the same. He has designed a unique varifocal IOL with Dr. Kakadia. He has many innovations in his name, like the Traboclean for glaucoma, the OmniFlow, a glaucoma drainage device. And he has presented many papers in national and international conferences. And he has also received many awards. We have Dr. Meghur, Dr. Deepak Meghur. He basically heads the cataract and glaucoma departments at the Meghur Eye Care Center in Bidar, Karnataka, specializes in complex cataract surgeries. Is passionate about teaching and sharing surgical skills through his YouTube channel. He's very prolific on YouTube and has thousands of followers on YouTube who religiously watch his videos. He has many awards and recognitions internationally. He has the ASCRS Best Award in 2023, and he has Vidarbha Ophthalmic Society Lifetime Achievement Award, the CS Reshmi Award, Best Paper Session Cataract in AIOC 2018, Best Free Paper Cataract and Best Video at the Karnataka Ophthalmological Society, and a host of other awards. So I welcome him. And last but not the least, we have Dr. Kamal Kapoor. I asked Dr. Anil Shah that sir has not given any information. He said, Naam hi kafi hai. So, Dr. Kamal Kapoor, I welcome you too. I would now like to hand over to Dr. Pankaj Shah for the series of the discussants.
Thank you, Dr. Ame. Very good evening to all of you. We have galaxy of discussions also, and definitely we'll have a very good discussion today on this topic. The first discussion we have is Professor Muhammad Mizanur Rahman. He is Professor and Head of the Department of Ophthalmology of Bangladesh Medical College. Presently, he is President ISMS's Bangladesh chapter. Then we have our own Dr. Debashish Bhattacharya, sir. Yeah, he also needs no introduction. He is a founder, chairman of Disha Hospital, West Bengal. He was past president of AIS 2015-16, and he has several publications, Indian and international journals also. And his area of interest mainly is cataract and eye care health management. Next, we have a very dynamic Dr. Jatinder Bali, sir. He is NBEMS course coordinator at Hindu Rao Hospital and North Medical Corporation Medical College, Delhi. Presently the chairman of International Research Committee of ISMICS. He is chairman of the DOS subcommittee for Information Technology, Practice Automation and Clinical Informatics. Also library officer at DOS, and has many other posts to his names plus journals and publications. Welcome you, sir. Next, we have Dr. Yogesh Shah, sir. He is the founder secretary of ISMICS, past treasurer of AIOS, past president of BOA, and also member of ethics committee, and also recipient of gold medal at IRSI. So I welcome all the discussions, and now I invite speaker Dr. Shirish Thorat, sir, to get his talk on capsulorhexis, can opener, envelope, and linear relaxing capsulotomy, its merits and demerits. Sir, you can start.
Yes.
Dr. Shirish Thorat.
Yes. My slide visible?
Yes, it's visible, sir. Start from the beginning. Make it a slideshow from beginning so that it will be full screen.
Yes.
Click on from beginning. Yes, from there, correct.
Click there, sir.
Perfectly visible. You can start.
Okay. At the outset, let me thank Maharashtra chapter of ISMSICS, particularly Dr. Anisha, for the opportunity. The topic given to me is can opener, envelope, and relaxing capsulotomy. Capsulotomy is making an opening into anterior lens capsule in order to remove the cataract. And without going into the theoretical details, I'll move to the presentation. Friends, cataract surgery is now like a refractive surgery, and the most important step is a capsulotomy. Though CCC is a gold standard, can opener and envelope techniques has some role in some sort of set of cases. Going to the can opener capsulotomy. Can opener capsulotomy is performed by making a series of small tears in the anterior capsule using cystotomes. So, a circular opening is created into the anterior capsule using cystitome or 26 gauge needle, and this can be achieved by taking multiple radial nicks into the anterior capsule. And this whole process creates multiple series of irregular freely mobile capsules. The ideal size should be 5 to 6 millimeter in diameter. Now going to the video. So this is a mature cataract with undilated pupil. This is the perfect case for the can opener technique. The capsule is stained with the trypan blue, and the radial cuts are being made. There are multiple radial cuts, which is, performing the can opener technique. These small cuts just take the precaution that it should not induce stress on the zonules. Once it is done, you can see the plate of the capsule, which can be removed by the forceps, and the opening is created. So this is a removal of the capsule, and this is around 5 to 6 millimeter, and this creates sufficient opening to take out the nucleus from the bag after hydrodissections. So nucleus is getting out of the bag, though pupil is very small, so nucleus has no problem in getting out. Every procedure has some merits or demerits. In can opener capsulotomy, it has got a very less learning curve, and it is very easy to use in a small pupil, a mature cataract, where CCC by the novice surgeon will be difficult. Removal of the 12 cortex is easier in this technique. Easy placement of IOL in the sulcus, though it is not guaranteed in the back. Sulcus fixation is a must, and this can be used as a rescue technique for CCC. Some demerits of these procedures are it creates zonular stress in cases of weak zonules. The ragged edges and anterocapsular tear can go toward the posterior capsule and creates a posterior capsule tear also. It creates sometimes unstable capsular bag in cases of weak zonules, and capsular tanks may entangle into the eye port or simple cannulae, and bag become unstable. The biggest disadvantage is CTR cannot be placed in cases of subluxated cataract, and this is biggest demerits of this procedure. Now, going to the envelope technique, is also called a smiling technique or linear capsulotomy. In this portion, make a linear incision in a superior part of the capsule. 2 side skirts are made, or you can directly go with the 26 gauge bend needle, or you can extend these cuts with the Vanna scissor, and these cuts can be joined to form the complete rexis. So you can perform this after staining of the capsule. The central nick is taken. So side cuts are taken by the Vanna scissor to form the envelope. It resembles the envelope, the flap of the envelope. The 2 side cuts are now getting joined by the rexis forceps to get complete opening of capsule. It is just like a CCC, and it will facilitate this opening is sufficient for nucleus to get out. Eye is being done, and you can see the intraocular lens is going inside, and in the back insertion is possible with this technique. In technique 2, after hydrodissection and nucleus extraction is done, IOL is implanted in the back, and then after you can make the cuts to complete the rexis. Like in this case, in first case, we have removed the capsule first. Now in this case, we're removing the whole capsule and the capsule after the insertion of the IOL. But this step is more particularly useful for the extracapsular cataract extraction, where nucleus is getting out directly from the bag. So now, after hydrodissection, the nucleus is getting out with difficulty, and after the removal of nucleus and cortex, the lens is inserted into the bag, and then you can cut the anterior capsule of the size you desire. If you find it is a bigger capsule, you can make a second cut to complete the capsular opening. So now in the back capsule, in the back IOL is implanted and stability is guaranteed. The merits of this procedure is the safest procedure. It produces less zonal stress as compared to canopnar. It's safest in all white cataract. Almost intact capsular bag is there, and it facilitates cortex removal completely, ensures a successful bag implantation of PCIOL, and polishing can be done. But in this case, it is less stable as compared to CCC because one side is open. Asymmetrical capsule flaps can be done, and anticapsular tear can extend to the zonules. IOL tilt and decentration as compared to CCC and CTR is not possible as it is not complete. Moving to my last capsulotomy, that is relaxing capsulotomy. This is to facilitate easy removal of the nucleus from the bag in cases of hard, big nucleus, a black cataract, thin capsule, small and pseudoexfoliation cases. Technique in this can be achieved intraoperatively by taking relaxing incision either at 12 o'clock or two medium-sized relaxing capsulotomies at 10 to 12 o'clock, or some surgeon may take only one at 12 o'clock position. Going to the video of the same, this is a hypermature cataract. It is a very hard cataract. So after completing the rexis, we can enlarge the rexis. The nucleus is very big and is not coming out of the bag. So two nicks are being taken, one at 10 o'clock position and one at 2 o'clock position. So one is at 2 o'clock position, other is at 10 o'clock position. It relaxes the bag, it relaxes the stress on the zonules, and now you can find how this big nucleus is taken easily out of the bag without producing any stress on the zonules. And subsequently, with the help of visco expression is taken out. This is another case of relaxing capsulotomy. For the pause of time, I'll cut this. So the relaxing capsulotomy protects the zonules and the bag. A big and hard nucleus can be delivered easily, and in cases of pseudoexfoliation, post of capsular phimosis is reduced by taking multiple relaxing capsulotomies at different places. Some demerits of this procedure: sometimes it makes back unstable. Accidental propagation of the nucleus toward the PC can happen. Accidental anterior capsule can get into the dialer and cause zonal dialysis. Unequal forces may cause improper IOL centration. So friends, in all three capsulotomies, like fish mouth capsulotomy or linear capsulotomy, the can opener capsulotomy, this is fish mouth, this is can opener. If you find these openings are small, you can always take a side cut to complete the relaxing technique. So you should know which technique to use at what time for better centration, better stabilization, and long-term safety of the IOL as well as patient vision. Thank you. Thank you.
Thank you, Dr. Shirish, sir. It was really very nicely and simply explained in such a beautiful way. We'll have the discussion later on. I invite the next speaker, Dr. Rajendra Prasad, sir, who will guide us on sieving needle capsulorhexis to avoid Argentinian flag. Sir, please.
Yeah. Okay. Thank you very much, and good evening, everyone. And I thank you, Dr. Amulya, Dr. Kulkarni, and everyone, Dr. Shah, for giving me this opportunity to be here with all of you in this beautiful evening. And I thank MSICS for the opportunity. The topic which I'm going to talk about is the continuation of the capsular axis, and the technique which I'm going to talk about is the saving native microcapsulotomy to avoid Argentinian plaque sign and intermittent white cataract. So these are the cataract we come across quite a bit in our clinical practice. And many times we tend to find problem in completing the axis, and we get into the problem of capsular tear extension, and later on the associated complication of the tear extending into the posterior capsule also. We do not have any financial interest in the subject matter of this presentation. So you know that the intermittent pearly white cataracts, you can group them into 4 groups. Intermittent soft immature white cataract, where you have a hyperhydrated fluffy material with milky white fluid, and just a second, with milky white fluid and soft nucleus. The type 2 could be intermittent mature white cataract with swollen and flocculent cortex, voluminous soft nuclei, and moderately hard nucleus. And type 3 could be intermittent hypermature white cataract with the partial cortical liquefaction. And normally we see a yellow and brown hue to the central portion of the cataract because of the hard and yellowish nucleus. And most of these cases are thin and fragile dense capsule. Type 4, you all know that it's a Morgagnian white cataract with total cortical liquefaction. And generally, we have a very dense and hard nucleus. Now, the important point why I'm trying to classify these intermittent white cataract, because each and every case presents differently, and you have to use the technique in a situation that, and looking at the type of the cataract. Now, this classification can be done with the help of the slit lamp examination itself, but we can take the help of the OCT images, and OCT images could show many of these changes in these white cataract. And the important point, what we can see there is the shallowing of the anterior chamber. And the second important point which you need to look at is the tense and stressed out capsule. So this is the important feature, and many of these cases would present with the multiple fluid pockets in the cortex. So these classification is important when we are trying to do the capsular axis in a different situation. And commonly, all these cases have a very thin and fragile capsular bag. That is the most important point, and they all have a very high interlenticular pressure. Now, what happens if you try to prick and start the capsular axis in these cases? You could see a volcanic eruption of the fluid which is coming out of the capsular bag, and the pressure which is going to be released with the puncture we make on the anterior capsule. This is how you see many of these cases would have the liquid which comes out in a force. And this force is important because when you are making the capsular axis in these cases, and when you make a puncture, then what happens? Because of this pressure which is going to release out of the capsular bag, tends to act on the edges of the puncture you made on the capsule. And the forces tend to open up the puncture and leads the puncture to extend to the periphery radially. And you find that these puncture actually opens up and it transforms into a Argentinian plaque sign. So this is what happens. Now, if this happens in these cases, if suppose we get an extension of the tear, then we are actually worried about the extension of this tear into the posterior capsule. And before we start any kind of the removal of the nucleus or the emulsification of the nucleus, we have to be sure that this tear hasn't extended to the posterior capsule. Now, this situation has been named as a Argentinian plaque sign by the Perronnet somewhere in 2000. And because, as you can see, this tear is exactly similar to the Argentinian flag with a white strip in between and around the blue strips. Now, what is the mechanics? So why it happens, like why the tear extend to the periphery? The Perrone has given a few theories why this tear extend to the periphery. He said that it is primarily because of the raised interlenticular pressure, and there is a posterior to anterior compartment pressure. So as you can see here, the posterior to anterior compartment pressure. And thirdly, the forward thrust of the nucleus on the back of the anterior capsule. And if you have a puncture here, now this forward thrust of the nucleus leads to the opening of that puncture in the capsule and tends to extend to the periphery. But then we have actually published, and which has been very well accepted, the very important theory is the configuration of the initial puncture, how you make the puncture on the anterior capsule. Because this is very important. We could use 26 gauge needle to puncture the anterior capsule. We could use cystitome. We can use other devices also to make the puncture, and the capsular access forceps also. So these are the types of the puncture we make on the anterior capsule. Now, this is very important because the type of the puncture you make on the anterior capsule is the reason for the extension of the tear. Now, I'll just show you a few basic points, because when you puncture the anterior capsule with the help of the 26 gauge needle or hypodermic needle, we are actually making a cut on the anterior capsule. So this is a linear cut which is made on the anterior capsule with the hypodermic needle. Similarly, when we use the capsular access forceps, or when we are puncturing, making a can opening, or whichever type of the capsular access we try to make, so we are basically making a tear on the anterior capsule. This is the capsular access forceps being used, and we make a tear, and then we start the capsular access. So now this tear is very important, because what I'll show you later why it is important. Because if you make a tear on the anterior capsule while puncturing, so we know that if there is a high pressure within the capsular region, there could be a release of the interlenticular pressure through this puncture. And the second important which happens is the volcanic eruption of the interlenticular fluid. Now, these pressure triggers off a disruptive force. So disruptive force starts acting on the edges of this tear which is made, and this pressure actually starts the opening of this tear which we have made on the anterior capsule. So you can see here in this animation video, because you make a puncture which is a linear cut, and this linear cut starts opening up and extend to the periphery in the form of the Argentinian flag sign. So how to prevent it? How to prevent this linear tear formation into the Argentinian flag sign? So actually, the important point is, because since you have a very high pressure, so before we start the capsular access, we need to release the interlenticular pressure and decompress the bag. So if you are able to decompress the bag, then making the capsular access would be very easy, and you can prevent the extension of the tear to the periphery very easily. So how to do it? There are several techniques which have been published because of the complexity of the situation. We can see the many techniques which have been published. And but to add this, we have published and devised a technique which is called as the sieving needle microcapsulotomy. The concept of this technique is, because if you are making a tear on the anterior capsule, the linear cut configuration, the forces can act on the open edges and which opens up. If you make a hole instead of cut, if you can make a small hole, puncture at the center of the nucleus, center of the capsule in the form of a hole. Now, if you have a circular hole in this capsule, this would have a more resistance against this pressure. And it's unlikely to extend to the periphery, because if you make a hole, the concept is like we make a micro rhexis and a small mini rhexis in the anterior capsule. Now, this is the publication we have made, and you can see how it works. So this is the device we have invented, and this device is known as the sieving needle microcapsulotomy. Now you can see the difference between the needle and this device. The needle, it's a pointed needle. When you puncture the anterior capsule, it makes a hole. Unlike this is the hypodermic needle, when you puncture the anterior capsule, it makes a cut on the anterior capsule. So there is a difference between the puncture. The one device is making a hole on the anterior capsule and the other device is making a cut. And you know that this cut is more susceptible to the pressure and it opens up very easily. This hole may not be, because this hole will never extend whatever is the pressure inside the capsular bag. And now you can see here in this video, because this is the animation video, if you make a puncture with this device, the center of the capsule, it makes a hole, and the fluid and pressure will evacuate through this hole, and you can prevent the extension of the capsular tear. And similarly here in this intumescent cataract, because I'm using this microcapsulotome, this is the initial development of the microcapsulotome, and when you puncture, you make a hole, and this hole actually releases the pressure as well as the fluid. Once you release the pressure, then we can very easily start the capsular access and without any threat to the extension of the periphery. Now this hole actually, because why I classified the intumescent cataract into the various groups is because the technique has to be different, because if you have a complete liquefaction of the capsular within the capsular bag and the complete liquefaction of the cortex, you can just make a one hole at the center. So this is sufficient to release the pressure within the capsular bag. But many times, if you have a multiple fluid pockets in the bag and a little fluffy material, then you may have need to make a multiple punctures on the anterior capsule. But the important point is these punctures have to be made within the 5 millimeter zone. You don't have to make this beyond the 5 millimeter zone, because in any case, because you make when you make the capsular access, it has to be within 5 millimeters, so that we could make the capsular access of 5.5 or 6 millimeters in size. This is one case you can see here, and this is intumescent cataract. So we normally what need to do is always stain the anterior capsule so that we know the progression of the capsular axis. And this is the device being used. Just puncture at the center of the capsule. And once you puncture, so you could see the some fluid which will escape. And many times you may not see the fluid. It's just the pressure, because there is a gas also within the gas will release. You may not see the fluid, but the pressure releases. Just with the single puncture, you can release the pressure. And then you can start the capsular exit. This is how you can complete the capsular access. I'll just show you a few videos, a very short video. And this is the device. What you can see here, again, this device, this is the important point is because see the tip, it's a round and pointed tip, like a saving needle. You must have seen the saving needle. It's similar to saving needle, which we use to stitch the cloth. The pointed tip. Many times you may come across, because when you are puncturing the capsule, you may see a small flap is being made. But if you are able to make even the flap also, would prevent the extension of the capsular tear, because then the pressure is distributed all around. This is how you make the puncture at the center. So this puncture would release the fluid. And once you release the pressure from the capsular bag, then you can inject the viscoelastic to pressurize the capsular bag, and this rest of the fluid can be milked out with the help of the cannula. And once you make it, then you can make a tear on the capsule starting from that puncture, and then you can start the capsular access very easily. Now, once you make a capsular access, you can go ahead with the 5.5, 6 millimeter capsular access, and then any kind of hard nucleus or any nucleus can be very easily evacuated in a small incision cataract surgery or MSICS also. You can remove the nucleus very easily through this large capsular access. So this is the literature which is can go through the various types of the capsular access being done in intumescent cataract, white cataract. And to conclude, this technique is very simple to perform, because you just need a needle. You can even use the saving needle at home. You can just bend the tip and puncture, or you can take this device which is available with the trade, and it's very highly effective and adequate. You know that adequate bag decompression is very important in these cases. So you can prevent the Argentinian flag signing 100% of the cases to make your surgical process safer and easier in the next step. So thank you very much. I'll stop my talk here. And thanks. This technique got the Best Film Award and Best Technique Award in ASCRS 2022. And now this technique is being used by many of the ophthalmologists in India as well as abroad also. Thank you very much. Thank you.
Thank you, sir. It was really very innovative video. Yes, RC, sir,
Dr. Prasad,
Yes,
what
sir.
is the best method of completing the rhexis after your sewing method? Is it forceps or the needle?
I use in 100% of the cases forceps. So forceps is always better because you have a much better control on the flap. You have a much better control. You can change your mechanics. You can change your forces as you need, which you may not get with it, because the people use both the technique, use the needle also to cystitome to complete the rhexis. But I prefer capsular rhexis because I don't use needle at all, because I just use in 100%.
So actually with the intumescent cataracts, if you've let the fluid out, now you've got a slightly floppy anterior capsule.
Yeah.
So with a floppy capsule, it's much easier to use a forceps.
Yeah.
But of course, once you are comfortable with the cystitome, everybody is doing it with the cystitome for that many years.
Yeah. And especially as you have very rightly pointed out, Dr. Bali, very right point you have pointed out, because once your capsule is relaxed and it's decompressed, then it becomes very difficult to use the needle. You cannot use the cystitome, because it's always better to use the capsular rhexis forceps, where you have a much better control on the flaps of the rhexis.
Interestingly, some people have been actually talking. I like in one of the presentations some time back, this was being discussed, and somebody mentioned that one day before the surgery, what they do is they do a YAG capsulotomy of the anterior capsule, and then they operate the case the next day. So
That's
that
right.
also sounds good. It decompresses, gives you 24 like whatever 18-20 hours to decompress.
Yeah.
We'll have
I showed you the list of techniques being published and used by various authors. But what is important is, because the important point is, you have to take the simplest technique, safer technique, the most simplest and the safest technique. See, using capsulotomy a day before may not be that safe, may not be that easy. See, using just a simple needle during the surgery, just puncturing, it costs 1 rupee needle. And the cost is very important, because in India, economics is also important. Some people using many techniques.
I'm sorry to interrupt, sir, here. I think we will get through all the speakers first, and we'll have a lot of time for discussion.
Sure.
Yeah, thank you.
I invite Dr. Kamal Kapoor, sir. He will be speaking and guiding us on innovative inverted T technique for capsular rhexis.
Okay. Can you hear me? Am
Dr.
I audible?
Amit?
Yes.
Am I audible?
Yes, sir.
Okay, so I guess I must thank the MSICS chapter. Of course, I am a pure diehard phacosurgeon, but it's good always to learn. I learn the MICS from my fellow junior surgeons when they do it. But I think this is a very, very interesting topic which you have picked up. And as luck would have it, whenever I go, I see Dr. RP just go before me. And most of the sessions in capsule rhexis, he finishes his session and then I take over, even at the AIOS. And coincidentally, this video has been selected for the, some videos I'll be showing are selected for the ESCRS for the competitive video section. So let's see how it fares.
So we finally got hold of your CV, sir, and
actually I sent it, but somehow there was no signal, so it didn't go. I only checked it that I thought it was gone, but it didn't go there.
Yeah. Anyway,
okay,
please
so
go ahead with your presentation.
I'll go ahead with my presentation. First of all, screen share that. So you tell me when you can see my presentation. Is it there?
Yes, sir.
Now we can see
now
it.
it is there, sir.
Okay. So I think before we start, just like what Dr. RP said, let's understand the anatomy of the capsule. The anatomy of the capsule is, let's face it, it is thinnest at the posterior part and second thinnest in the center. So most of us start our rexis from the center with a needle cystitome or a rexis forceps. That's where the problem starts. If you go to the mid-periphery, that's the thickest part of the capsule. That's what my experience and my videos are going to be talking about. So unlike what Dr. RP was saying, that's a beautiful method of doing it. I concentrate my capsulotomies at the mid-peripheral part, which is the junction of the central 2/3 and outer 1/3. And this is a technique which is not only useful for managing the hypermature or the intumescent cataracts, but it is a technique I employ to manage any situation in capsular rexis. Now, this is an intumescent cataract. This is again an intumescent cataract where the rexis is just about to go, so it's a freeze frame of the session. Another bulging capsular rexis in an intumescent cataract. This is a technique used to even manage a running out capsular rexis. If your capsular rexis starts running out, how to manage it? A technique managed to repair or get in control a torn, perforated, traumatic capsular rexis where it's all irregular, burst like a star shape. My T technique comes handy to save the situation. And even in situations where the peripheral tear it's extended out, and how to manage it and get it back again. And a similar situation of a run out. And how to manage an Argentinian flag sign once the sign has happened. Once something which you were anticipating not to happen has happened, how to use this technique of mine, the T technique, to manage such a situation. So I call it the reverse T technique. And as I said, the central part is the thinnest, and the thickest part lies between anything between 5 to 7 millimeter. So my technique will be focusing on the thicker part of the capsule where the chances of running out are less. Why we have this run out of the capsule rexis in an intumescent cataract is central part of the capsule being the thinnest. There's a lot of intralenticular fluid just beneath the central part. The moment you puncture it, and as Dr. RP said, it just runs out, explodes like a volcano. The zonules are at the periphery, again extending it with this zone of 6.5 millimeter. There are no financial disclosures for this particular presentation, and this is what I was meaning by it. So suppose your capsular rexis tends to run out. The most feared complication, even in a non-intumescent cataract, is if it runs out, that you could have a nuclear drop, or you could have a peripheral extension of the capsular rexis, which ends up, creating a situation which is unwanted. You could have a nuclear drop, a complete cataract, dropping into your vitreous. So I'll be describing this technique where I will be showing that first you make a side port. Let's suppose this is an intumescent cataract. You instill your trap and blue dye. You instill your dye. Then you put in viscoelastic. And once you put in the viscoelastic, I'll just fast forward it. The dye is going there. Then you make a small port. Remember, this is not a complete wound. This is a very small wound because I want to keep the intra pressure of the anterior chamber very high. So I make a semi wound to start with, push in a lot of viscoelastic, which presses my capsule down and flattens it. Once the capsule is flattened, a small wound ensures that when I'm trying to puncture, there's no sudden release of viscoelastic. So then again, you push viscoelastic on top. And then after that, you need a 26 gauge needle bevel downwards, bent with 0.5 cc fluid in the needle. The reason why I want fluid in the needle is fluid is less compressible than air. So if I suddenly start aspirating from the intralenticular space, I may just pull some air, and the air being expansile, I may not create enough vacuum. So I keep a half a cc of fluid in the syringe, and then I start aspirating. And once that is done, we start decompressing the fluid. Once this is done, push in more viscoelastic. Now this viscoelastic has a steamroller effect. It pushes the nucleus downwards, and all the fluid accumulated behind the nucleus also comes from this linear cut. Once this cut is there, now I extend my wound to a normal wound of 2.8 or 2.2, use a 1 hour and cut the linear cut which was created by the needle. This creates a reverse T Now I push in more viscoelastic, and all I need to do is touch these two flaps. Now let's see this in real life. Now see this in real life. This is a situation. This is again a white intumescent cataract. So I decompress from the side port. Of course, now I bend the needle 70 degrees, bevel downwards. Notice there is some fluid into the syringe. This is approximately half to 1 cc, whatever you're comfortable with. A semi-wound. In one puncture, I go at the junction of 2/3, 1/3, just one puncture. And within that puncture, I start aspirating. And you will see the fluid starts getting aspirated. The anterior capsule starts getting flattened. And once this is done, my intralenticular pressure is reduced. And I have a linear cut. Now, the move has to be in one go. The moment you puncture, start aspirating. Now you put more viscoelastic on top. And then now you enlarge it with a normal size. Now, because I'm not afraid of decompression of the anterior chamber, use a 1/2, create a T-shaped cut. There you are. Now you have two flaps. Each flap can be turned to the direction you want, the shape you want, the site you want, and the size you want. This technique I will be showing using in various complicated situations of, wherever there is a little situation with the capsule rhexis. So you can use in this situation, you can use a forceps preferably, as beautifully pointed out by Dr. Bali, but you can also use your bent cystitome to do this particular step. Now, since you have two flaps, you can have any size, any shape, any direction, or any site of this capsule rhexis. In case one starts peripherally, going out peripherally, you can hold the other one and bring it in. This has worked. I've been doing this for last 8 years. Everybody in my organization, especially for intumescent white cataracts, all my joinees, all my new doctors, they are taught this. And once they are taught this, they usually don't have any problems with this technique. Now, this is an intumescent phacolytic phacomorphic glaucoma. Intralenticular pressure is very high. This is a proof. This proof shows that it actually works. You can see the cornea is also hazy. We gave mannitol to this patient. One go, suction of fluid. The reason why I'm not going in the center is, suppose if this puncture was in the center of the capsule, that's the thinnest part. There's a lot of fluid there. It tends to burst. So over time, I've learned that this technique works 100% of the times if I make the incision peripheral 1/3 and junction of central 2/3. This is the thickest part of the capsule. It is less brittle. It doesn't tend to run out. So even in this kind of a cataract where there's a phacomorphic glaucoma with a high pressure, intralenticular pressure, you can complete the rhexis the way you want. You can use a forceps. There again, a beautiful rhexis done. Now let's see some other situations. Now, in case there is a peripheral runout, how to do this? Now, this is a graphic detail of the capsule running out peripherally. You can make another incision, put the needle in, again create a linear cut. Once that cut is there, cut it with 1/2, and then again you have two flaps, and then you can join these two flaps. Now let's see in the video. This is a situation where there's a runout. All I need to do is bend the needle. I'll just fast forward. Here go in, make a linear cut, use the 1/2, have a beautiful T, and you're back in business. So anytime you have a capsule rhexis problem, the reverse T will help us out. As Dr. RP says, minimal cost, just cost of one 26 gauge needle. So this saves the situation. Let's see another situation. I think I'll jump this video. Now, this is a situation where one of my juniors who just joined from somewhere else was operating in another center, my Patna center, and I was just visiting them. And I was just called to the OT. They had an Argentinian flag sign. See how we manage this using the T technique. This is a complete Argentinian flag sign. There is a raised interlenticular pressure. I've given an incision just to create a nick. And now I will again use the T technique, puncture, and in the area where the flocculent material is pushing the rhexis out, I aspirate and see what happens. The moment the interlenticular fluid is reduced, the capsule falls down. I have a straight linear cut. I cut it with the 1/2, again create a T with two flaps, and all I need to do is use these two flaps to create a rexis, and the first nick I do is completes this, and this saves the day, and you can go ahead and finish your surgery. Now let's see another situation. This is a patient with a perforation, a star-shaped capsule rexis tear. There is an incarceration of the iris. So the aim was to do a complete capsular rexis, finish the surgery, do a single throw 4-pass technique. Now see what I'm doing here. I'm trying to initiate a cut. Again, use a microforceps to create a T. Two flaps are created. T is created. This is a star-shaped tear. Now using the left hand and the right hand to complete the rexis again and creating a symmetrical area of tear from that area which was star-shaped. And once this is done, we go ahead, we put in the single throw 4-pass suture, complete, iris repair, the torn iris tear is repaired. And then the patient, this was a 14-year-old girl, her brother hit her with a TV remote control, and she landed to us after 4 days of surgery. So this is what, I've just went fast forward for you. Thank you. So you can use this inverted T technique to save many situations once you master it. So key points are, do not make a big wound from where you're puncturing. Make enough viscoelastic to depress the capsule. Puncture at the junction of outer 1/3, inner 2/3. And the moment you puncture, start aspirating. That's all you need to do. Thank you.
Thank you, Dr. Kapoor, sir. Nice presentation with very good videos. I invite next speaker, Dr. R.C. Shah, sir. He will be guiding us on precision and accuracy in capsular rexis creation. Sir, you can start your presentation.
Thank you, all of you. Can you hear me?
Yes.
Yes. See, I'll be, thank you, Kamal and Dr. RP, who has made my life very easy. The capsular rexis basic and future development. I'll be talking what is going to happen in future. This is a small thing which Dr. Kiranji Singh has taught us, so which is not yet been covered by any of these lectures. So I'm just trying to cover up the same thing. Classified mature cataract into 4 with the help of OCT. OCT1 is regularly organized cortical fibers without any gaps. OCT2 is hyperreflective fibers with some amount of gap in between the fibers. Third one is intralenticular cleft with homogeneous ground glass appearance. And the fourth one is homogeneous appearance throughout. Out of all these 4, OCT2 is associated with the highest risk of AFS. This is what Dr. Kamal has shown. The anterior portion of the central portion of the anterior capsule is the thinnest, and the thicker one is there in the periphery, and that is what we take the advantage. The retrocapsular high pressure leading to Argentinian flag sign in mature cataract. The thin capsule, not the ring, the shallow chamber, and the retrocapsular. Now I have slightly modification of using the Trifine blue. Use Trifine blue to stain with minimum of 1 minute, preferably 2 minutes. What happens, when you Trifine blue reacts with the anterior capsule, it causes C3R changes, which makes the anterior capsule tough. Start the rexis in the periphery, not in the center, as Kamal said. This will allow to decompress the capsular bag. The capsule is thicker in the periphery compared to the center, and the C3R changes induced by Trifine blue will prevent irregular, uncontrolled tearing of the anterior capsule. Use 23 number needle. I want to try to use sewing needle in the periphery. Probably next 2-3 months I will use it. Use 26 number needle and the rexis forceps judicially whenever it's necessary. We rarely see Argentina flag sign in this method. I'll show the video. This is a Trifine blue which is kept for more than 1 minute. I use both. I always use methyl cellulose first and then both hyaluronic acid and chondroitin sulfate, so my chamber will not shallow. Bend the needle up to 60 degree, not more than 60 degree, and bend the needle at the junction of white and the stainless steel. This video is recorded with our own camera system. Small nick on the periphery. It will decompress to some extent, and rarely this will give away to form the Argentina because it's a very thick capsule has come to center, and with the help of C3R changes into anterior capsule, we rarely see the capsule giving away. I think the point of refined blue keeping for 2 minutes works very well. And it will be useful in any method of rhexis in mature cataract. Now I'm coming to our new innovation. We are going to have 2 innovations which will help all of us to have a good, automated, strong rhexis.
Hello dear friends and colleagues. Today we are very happy to introduce to you Capsulopen, the radio frequency device to do a nice capsulotomy. This is how the small and portable shoebox size console and the RF cord look. Console is known as RadioPen, which has 2 functions, Capsulopen and Trebopen. Trebopen we already have learnt about, and let us now learn more about Capsulopen. The word Capsulopen is an acronym derived from 2 words, capsule and open. It is also a pun of capsule and pen because it works just like a pen in doing capsulotomy. This is the magnified view of the Capsulopen's RF cystitome tip. Please notice that it is round and pointed like a sewing needle without any sharp sides or cutting edges. The RF cystitome is assembled on the RF cord like this, and both the things are reusable by autoclaving. This is a white mature cataract, and as we can see, we can quickly perform the capsulotomy just in about 7-8 seconds. This is an unedited real-time video. This is a case of congenital cataract with a dense posterior capsule plaque in a 3-year young child. It is so safe and so easy to perform a capsulotomy even in a 2-year, 1-year child. We are never afraid of rhexis running out. The control is always there, and the coagulated margins become so strong that it is impossible to tear them. The anterior capsulotomy is over. The cataract is aspirated, and now this is the posterior capsulotomy being done to remove the plaque. And as you can see, the posterior capsulotomy can be done very easily. We can re-engage, retouch, and re-engage, and the entire procedure can be done without disturbing the vitreous phase, because this wavelength 555 kilohertz is absorbed only by type 5 collagen, and it is not absorbed, this energy is not absorbed by the vitreous. This is a case of donut-shaped membranous traumatic cataract in a young boy with strong fusion of anterior and posterior capsules in center. With Capsulopen, we can easily do anterior rhexis, which otherwise is very difficult even with diamond knives in membranous cataracts. After removal of the donut-shaped thick sommering ring, we can also do posterior rhexis to remove the dense plaque with without disturbing the vitreous phase, because this radio frequency of 555 kilohertz is selective only for type 4 collagen of capsules, and the vitreous is immune to it. After the complete 360-degree Raxis by the radio capsular pen, we can remove the plaque without disturbing the vitreous phase easily. So capsular margins are so strong that it can be stretched almost up to equator without breaking or tearing. Thank you very much for your patient listening.
If you have a time, we have one more, the laser capsulotomy equipment. If there is a time, I can show the video of about 5 minutes.
You can show that, sir.
Yes, sir. So you're showing it now?
Yes, yes.
If you want me now, otherwise, whenever you want.
You can continue.
Show it right now, sir. Show it right now, sir.
I think, let me find out. You can go to the next presentation. I'll come back again.
Okay.
Yes, sir. Now we have Dr. Deepak Megur with us. He will be talking on capsulorhexis in challenging cases and its management. Dr. Megur, sir, please.
First of all, thank you for the opportunity. I hope my screen is visible.
Yes, yes.
Yes, it's visible, sir. Make it full screen, sir.
See, I'll be speaking on the calcified capsules. So now we just saw a very high-tech way of managing the thickened plaque and capsule. See, traditionally we have been using the micro scissors and forceps to cut the calcified capsule for opening the capsule. So I'd like to present a newer way of managing them, and let me take you through a few case series here. So it has an audio, I guess. Just let me know whether the audio is there.
Anterior capsules, they're calcified, typically seen in long-standing senile mature cataracts. They're difficult to deal with. They can either be cut or torn. If we are forceful with our maneuvers, we end up putting a lot of stress on the zonules, and there can also be a radial extension of the tear. So they are unpredictable. So how do we deal with this challenge? Well, there's a secret to solve this mystery. To know the secret, we need to open our eyes wide and look at this capsule very closely. Where do you think this white calcified plaque is? It looks as if the anticapsule itself is calcified and the plaque is embedded in it. Well, that's not right. Now here is the secret. The calcified plaque is actually subcapsular, and the anticapsule behaves in an unpredictable manner simply because of this plaque. If we can somehow manage to remove this plaque, then the anticapsule would behave in a normal way and the rhexis can be very well be performed. Now the challenge. How are we going to get rid of this plaque? It is under the anticapsule. So we have a solution for this puzzle as well. We call it as a 3-point strategy. Creating a small primary rhexis, this acts like our door to reach the underlying plaque. Number 2, dissect out the plaque from the attachments with the overlying anticapsule and then extract it out. And lastly, perform the secondary larger rhexis on the anticapsule, which is now devoid of the plaque. Let me demonstrate these through a few cases. This is an elderly patient with an hypermature cataract with a calcified plaque. The arrows denote the extent of the calcified plaque. I begin by puncturing the anticapsule, and it's quite tough to even get any sort of a cleavage. You can see the entire bag is moving and the stress in the zonules. With little difficulty and perseverance, I could raise the flap and eventually complete a small rhexis, which is about 2.5 millimeter in diameter. Now is the time to deal with the underlying plaque. I'm creating a cleavage plane under the capsule by using a combination of visco and blunt dissection. Using a micro forceps, a part of the calcified plaque is gently peeled out after separating it from the overlying anticapsule. As we can see, a ring of calcified plaque continues to be present under the capsule, and some of it are extending towards the equator. Using a forceps, this plaque is held gently and then being dissected slowly but surely from the overlying capsule. The combination of viscodissection and blunt dissection is repeated to separate the last few attachments of the plaque with the overlying capsule. Finally, the entire plaque is gently pulled out. And in the absence of the pathological plaque, the anterior capsule behaves just fine, as if nothing was wrong with it in the first place. The rhexis is enlarged. This is how it looks. And here are the before and after pictures. The nucleus is emulsified. Well, the case essentially becomes a routine one once the calcified plaque is taken care of. Moving on to the next similar case, an elderly patient with an underlying calcified plaque. Please note, one of the limbs of this plaque is extending all the way up to the equator. We are going to follow the same principles, the 3-point strategy: make a small rhexis, dissect out the plaque and extract it out, then make a secondary larger rhexis. The small primary rhexis is created. The liquefied cortex is cleared off to enable visualization. In this case, I'm using a micro-iris spatula to break the adhesions between the capsule and the underlying plaque. With a little bit of patience and perseverance, the underlying plaque could be dissected away from the anterior capsule. Part of the rhexis is being enlarged. Now is the time to remove the plaque. A part of the plaque has extended towards the periphery up to the equator, and this is tricky. So excessive force would cause zonal adhesions. I'm using a second instrument to provide some contratraction, and carefully, with gentle pressure and persistence, this plaque could be pulled out. And here are the before and after pictures. The case essentially becomes a routine one once the calcified plaque is taken care of. In this third case, we have an eccentric plaque extending towards the equator.
See, again, the secret is first make a
Primary
small
rhexis is
opening.
attempted but could not be completed, but we still have access to the underlying plaque. Carefully, the plaque is dissected out from the overlying capsule by using 2 microforceps to dissect it. Once the plaque is out, the second rhexis is completed in a controlled manner. And phaco could be completed and the lens put in. Case number 4. We will encounter a few cases like this one where the zonules will be inherently compromised and which would require a CTR. And CTR is possible only if you have an intact rhexis. And that is possible if we take care of the underlying plaque and then get the rhexis right. I'm creating a cleavage plane under the capsule by using a visco dissection. Using a forceps, a part of the calcified plaque is gently peeled out. Once the calcified plaque is taken care of, the chamber is pressurized with OVD. A little bit of OVD is placed under the capsule to create some space between the nucleus and the entercapsule. CTR is threaded. CTR goes in and it is going to provide us equatorial support to the capsular bag. The case essentially becomes a routine one and phaco could be completed. The lens put in. Does this technique work in all calcified and fibrotic capsules? Well, to answer this, I would like to classify these capsules into two distinct variants. Number one, the one with a well-defined subcapsular plaque, which we described earlier. The second variant is the one which is composed of fibrotic bands more often, and they have less of these broad plaques. The one with the plaque is typically seen in long-standing, mature, age-related cataracts in the elderly, while the fibrotic variant is often seen in young patients with long-standing traumatic cataracts. In these fibrotic cataracts, creating a cleavage plane first, followed by creating a capsulotomy with a vitrector, gives good and controlled capsulotomies. In this clip, we can see the fibrotic capsules being cut very effortlessly by the vitrector without causing any stress on the zonules. To summarize, we need to classify the calcified capsules into two distinct groups. In the eyes which have a subcapsular calcific plaque, our three-point strategy of creating a small primary excess, dissecting and extracting out the underlying plaque, followed by a secondary larger excess, gives the best outcomes. To deal with the fibrotic variant, we would prefer to use a vitrector to provide a predictable circular and appropriately sized opening. Thank you.
Wonderful, sir. Really.
Thank you, sir. So I think we should have just a little bit of patience. That's the only skill which is required, apart from diagnosing the two variants. Once if you can differentiate the two variants, if you have a little bit of patience, identify the plaque and dissect it out, it would help us well.
Thank you very much, Dr. Meghur, sir. Now the forum is open for discussion. I would invite Dr. Rahman, sir, to give his inputs on today's talks and his words of wisdom for the same. Dr. Rahman sir, please.
Yes, thank you very much. I think every speaker, they have nicely shown the capsulorhexis and capsulotomy techniques. And first of all, Dr. Shirish Thorat, and he has shown the basic methods for canopilar method and also the in-blood technique, and it is a very safe technique. Sometimes the curvilinear capsulorhexis continuously, it cannot be done. It may tends to extend radially. In that case, the canopilar method helps us. And I preferably start the canopilar method from 6 o'clock position, and it extend towards the clockwise. Then again from 6 o'clock position to anti-clockwise at the position of 12 o'clock position. So that's the very nice basic techniques, especially for the beginners. It's a very good technique, and this technique is, I think, the learners, those who starts capsulorhexis, for them it is a very nice options. Secondly, the Dr. Rajendra Prasad, the interlenticular pressure where it is very high, how we can manage it, the central puncture of the capsule, and how to manage it when the intraocular pressure is very high, the lens thickness is more, and the intermittent cataract he has shown very nicely. And especially I prefer in this case where the lenticular pressure is high, to maintain the anterior chamber very deep with viscoelastic substance, and first making a central puncture for debulking of the lens. And we start a first small capsulorhexis, then we extend the second capsulorhexis. That is a very safe and good options for this. And the latest things I have seen, I was impressed. Dr. Ramesh, he has shown the radio frequency capsulorhexis, very nice. And Dr. Ramesh, you have any experience that in this technique, is there possibilities of radial extension of the capsules? I don't know. I have no idea about this radio frequency, but it is a very good technique and very safe technique, especially for posterior capsulorhexis in case of children. And Dr. Kamal Kapoor, inverted T technique from the mid-periphery, that is also a very safe techniques and very good options in case where the interlenticular pressure is high or in case of intermittent cataract. And lastly, Dr. Deepak Megur, he has shown the capsulorhexis, how to do in case of calcified capsule. And in the most of the case, this capsule is attached to the cortex, and sometimes there is a wrinkling in the anterior capsule, or the capsule may be fibrosis. And nicely he has shown the fragments of the capsule and the fragments of the plaque is removed, and finally the good circular capsulorhexis is done. So overall, it's a very good technique for the beginners, and I have learned so many things from these speakers, and they have shown very nicely. And I am grateful to Maharashtra ISM SICS chapter, and also Dr. Amulya Sahu sir and Dr. Jagannath Brahmani sir for inviting me in this webinar. Thank you very much.
Thank you, Dr. Rahman. Thank you. Devashish sir, waiting for your comments, sir. Please do help guide us.
No, it was a wonderful session on to do rhexis, and of course we did can opener capsulotomies before rhexis wasn't there. But I think talking about it in today's context is probably not advisable for beginners, because you catch those edges of the capsular openings because you think it is a bit of cortex which is probably left behind, and eventually we rupture the posterior capsule. If we all go back to our old days, we'll probably remember incidences like that. I think what Dr. Shirish said is multiple releases on the capsule if the rexes become small is a very good technique. And of course, the envelope technique he demonstrated very nicely. As usual, Dr. Rajendra Prasad's that concept of a sewing needle for a, making a hole instead of a cut. And of course, Kamal Kapoor's inverted T is something we have known for quite some time now, and it does work. Dr. Deepak Megur was fantastic with his skills, and he also explained that if you have a fibrotic capsule, then it doesn't work, and you have to have an option of your scissors or your radio frequency from Dr. Ramesh. Would like to learn more about it. Must be it is his own. Actually, one comes with the Otley machines, but off and on, I don't know. I don't have much experience on that, but Ramesh would really love to hear from you more. It must be your inventions, because both you and Rich are always there to invent and bring new things on our table.
That invention was the Fugo blade, which was originally designed.
Yeah, Fugo blade.
Daljit Singh was using this in the family. I also had one of this machine, but now that since the person is died and he has not transferred the technology to anybody, we are just trying to revive the same things.
Exactly.
It is not easy to make this again. And the one more thing which is on the process is the capsular, the green laser, which we are going to make it for all of us. At present, it is available at about 1.6 CR, but we are going to make it 1/6 of the cost. And it will be fitted like an Omni-Glow. It will take about a year's time for us to get that machine ready for all of us.
So the radio frequency knife, is it, are you reviving the Fugo knife?
Yeah, we are just trying
to forgotten, because especially the membranous, no cataract situations in, the pediatric traumatic.
It was such a wonderful.
It really works wonders in those cases.
It creates about 1,000 degree.
Vitrectomy cutters also do a decent job, but
even
are doing that and demonstrate.
Anti-glaucoma surgery, which I and Dr. Daljit Singh, is doing it with very great success rate, where you used to use 75 micron. It is almost like an eye stent, which is created by Fugo blade. Unfortunately, whenever it goes out of order, it is impossible for us to repair it.
Yeah.
So what are you using, the 100 microns or the 400 microns?
At present, I am not using anything because we don't have a machine. We have only one machine which is on the way to process it to make it for every one of us. It is under the trial. But 100 micron, we use 75 micron for open angle.
Wish you all the best.
And about 600 micron size to make a destructive filtration for a blind eye, painful eye. We use for anterior capsulotomy, posterior vitrectomy, and even in case of entropin surgery, it cuts like a butter. It's actually a manual excimer laser, which creates a temperature of 1,000 degree around 50 micron. And it creates the plasma with destruction of molecule and convert them into a plasma. So the heat is not transmitted, neither the charring is done. The healing is on the spot, next day only.
So, but they used to say that it is cold plasma. You're saying it is 1,000 degrees centigrade.
That is only tip of 50 micron.
Okay.
That is why it creates about plasma. Plasma is a 4-state of, one is metal, gas, then liquid, and the 4th one is plasma. And it is used in dental as well as the cardiac care. Unfortunately, the person died. Now the whole technology, so many people wanted to buy the technology, but it did not give it to anybody. And unfortunately died prematurely. We are just trying to revive it. It's not our original idea.
Great, sir. So Dr. Jatinder Bhai, sir, please give your thoughts and inputs on all these talks, please?
Sir, I want to, Dr. Shah, thank you so much. At the outset, I want to thank ISMSICS. I want to congratulate the Maharashtra chapter for being a beacon of light, showing the people how it is done, and fantastic presentations. And Dr. Thorat brought us back to the envelope techniques that we used to do with the MVR blade and those hypermature cataracts. You just take that slice in and slice out. And I think the take-home message from him was that, because in SICS, it does not matter what kind of an opening you have. This surgery can be performed, because it is a type of a rescue surgery. Whatever be the situation, it'll get you out of it. So I think the take-home message is this is an essential part of your armamentarium. If you are a soldier, yes, you can fight with machines. But when you have to fight with bare hands, that's when the true worth of the soldier is known. And that is why SICS is extremely important. And then, of course, Dr. RP's, Dr. Rajendra Prasad's micro needle sewing needle capsulotome is very famous, and that OCT classification that has been given, it has been touted a lot, but the bottom line, of course, is that wherever you have fluid inside an enclosed space, it will obviously be communicating with one another. So when we are doing it on the table, of course, we need to make multiple punctures. But then there has been this debate about doing a little bit of decompression a little time before. But yes, definitely life-saving, and the main reason was actually taught by Dr. Kamal Kapoor, that you see, it is what happens is, the moment you see that you see an intumescent cataract, a white cataract, you want to go in through the center and you want to puncture the center, and that is what you should overcome. And a lot of times people puncturing in the mid periphery would get away with it, while those in the center would end up losing it. And the main reason for that was that thickness that you tend to get with that. And then, of course, Dr. Kapoor's inverted T has been a lifesaver for all of us. And it's a fantastic technique. I wonder why it has not been discussed and demonstrated so much on the national and international stage. And so far as Dr. Shah was concerned, I've been following his Capsule Open and Trab Open, and I am actually looking forward to looking at that laser video that he was saying that he would show us. So what he's done is he's tantalizingly told us that when it ends, I'll show you. That's how you see those Saas Bahu serials. बिल्कुल क्लिफ हैंगर बना के सबसे एंड में दिखाएंगे. So we were waiting for that.
I could not open it that time.
तो अगली बार दिखाएंगे.
Yeah, you can see now also, if I want, I can try and show it.
With the permission of the chair, sir. With the permission of the chair. And then, of course, Dr. Megor, I must congratulate Dr. Megor for path-breaking ideas. For all these years, what we've been doing is we've been raising those plaques and cutting them with Vana scissors, and then having those rexes run out and then do some rescue SICS and give up phaco on that patient, or do just lower the parameters and finish the phaco and put the lens wherever you can put it. So I think my take-home message is from Dr. Megor's the plaques, as well as the fibrotic capsules. They are a nightmare, actually. So, but all thanks to all of you, it was a fantastic night of learning, and I'm still waiting for that video, actually, sir.
If you send me the email address on this thing, I can send it to you. If this is not allowed now, if the time does not permit, I can send it to you.
You better put it in the group only.
Okay,
he's right, sir. Dr. Bunamani is right.
Bunamani, I'll give it to you.
Yeah, sure. Sure.
Okay, sir.
I have a question for you. Is this capsule pen available?
No.
And at what
cost?
So
what is the price?
It's not available.
Not available. Okay.
You have to wait for some time because we are not sure of it. It's quite complex physics. And as a clinicians, it takes little time for us to understand also.
Dr. Shah, I had a small question.
Sir, in 1999, the artery machine has got RAF ruler. It's got the same principle. When the Treffen blue or blue dye was not available, we used to do this thing, RF ruler in the circular fashions. That is RF ruler. The principle is the same. So only that thing is that the procedure is blind. We need to move that RF ruler in the 5 to 6 millimeter zone and see to it that the capsule is coming or not.
Dr. Shah, there was this thing that it was something that was patented way back in 1999. So that means 20 years would elapse in 2019. So even if he has not transferred it, and he passed away in 2020.
No, it's not a question of transfer. It's a very highly complex technology, and most of the things were lying in the handpiece. The moment we open the handpiece, the whole thing gets destroyed. That is where the thing is. We can make the console very easily, but transferring that energy onto that is a challenge with us. Somebody has made from Delhi for us, which did not work that well as we had expected. When I had worked with the Fugo blade, it was so superior. And it was causing a lot of temperature rise, the Delhi one fellow. So we did not use it much.
So Delhi, everything causes a temperature rise.
No, he was very good. He has cooperated with us quite a lot. He worked very hard with us. And we could not manage to get, but now we are in the process. So we should be ready in a year's time.
Dr. Megor is asking something, sir.
Yeah, yes, I had a basic doubt, sir, but is it the same as the Earthly's RF cautery, or this is different?
Probably same, but that RF cautery they are made, they're basically using for the glaucoma surgery rather than capsule.
Okay.
They have one which is a glaucoma module with the software.
Okay.
Which costs around 5 lakh rupees additional for the glaucoma, and that works wonderful.
Okay. But it's not available for capsulotomy? Their original...
I have no idea about it.
But I used in 1998 for 1 year, the RF ruler of Earthly, where when the dye was not available. In 1998, I used for 1 year the RF.
But sir, did you try
Dr.
fibrotic capsules?
It does have that cataracts thing also, no?
I have
but
no
that's
idea.
I think.
Different professor. But one thing is definite about the glaucoma part, and we are on the process of making a small unit separate only for glaucoma. It will take little time for us because we are having a lot of things going on. So devoting time from the clinical practice and then going, it takes a lot of time for us. We are just trying to make something very good for glaucoma also.
Dr. Megor, can you make out the plug, whether it is subcapsular or wrinkling on the OCT itself preoperatively?
On OCT?
Yeah.
It might be tricky. Sometimes it is not, because everything is opaque, no? With all these hypermature cataracts. Sometimes the delineation is not very easily seen on the OCT, actually. So after staining with trypan blue, actually it is very well delineated. So sometimes it might be difficult even to get to know at the slit lamp also. But once you stain it, you will differentiate whether it's a fibrotic cataract or there is an underlying plaque. It's much more easier.
And Dr. Megor, I had another question. Like, does it work in every single case, or is it that it will work in a few cases and then
No. You have to understand first. You have to distinguish between the fibrotic variant, which has just the bands. It doesn't have a plaque. This is typically seen in young patients who have got long-standing traumatic cataracts. Younger patients, long-standing cataract, have the fibrotic variant, whereas an elderly patient who has a long-standing cataract will develop this plaque because the cortex gets solidified and then attached. So these two distinct variants you have to identify and then use the necessary technique. So plaques typically are seen in the elderly long-standing cataracts, and the fibrotic variants are more seen in the younger patients with long-standing cataracts.
So actually what we used to do was we used to avoid the plaque area and start the rexes from the other place, and then raise the plaque into the...
Yeah, that's the usual thing. But what happens, many times the plaques are so huge and spread, they'll be spreading.
And then you're using a Vanna's needle to cut it.
You can't go around it that time. If it's a small center plaque, you always go around it.
So many times these plaques are formed in the posterior capsule also under the nucleus. So do you find, have you come across that situation, like if you have a plaque in the on the back of the nucleus.
Yes, many
and
times,
then
many
with
times.
the capsule.
Yeah. Because the pathology is similar, long-standing cataracts.
That's
What
right, yeah.
can happen in the anterior capsule can also happen in the posterior capsule.
Yeah.
So many times I've done posterior capsulotomy rhexis also. So with the cutter. So many times it is quite common, sir.
That's right. So these are the cases. Actually, it is said that we should not rotate the nucleus before we are sure that there is no adhesion with the posterior capsule.
Dr. RP,
yeah.
How can you guide us how to make the sewing needle for our capsular axis from a
Any
regular
round needle,
sewing
sir?
needle?
It's very simple, sir. Like the needle which
It is not easy to bend, huh?
No, you have two types of the needle. One is alloy, the other one is the steel. So you have to ask for the better one, the quality one, which is made with the steel. That steel one you can bend it easily. But if it is made generally, the available needles are with the alloy. So alloy needle is not possible; it breaks very easily.
It's
but
not
if
easy
it is made with, if it is made with the steel, the quality one, then you can bend it.
Can we order them on Amazon? Do
Yeah,
we
yeah,
get
you can very easily. And
I think it is also available with some surgical manufacturer also, is it, sir?
No, even if you want to go in for the much better one, then these spinal anesthesia needle.
Okay.
The spinal anesthesia needle is also round tip and pointed round tip. So these are a little expensive, but you can use very well that also.
That's all.
Dr. Rajendra Prasad, I had one question. I saw one of your, I don't know where, I saw a particular presentation where, there was in the center of the round needle, there was a hole.
Yeah.
So where is that needle available from, sir?
No, that is still in production actually, because I have designed that. That needle has a central hole. After puncture, you can aspirate also the fluid from the interlenticular space, and but that is still under production. Many times people need actually, because if you puncture it, most of the cases, see, actually these cases, it's not only the fluid. Many of these cases, they have a gas inside. There is a gas within the capsular bag. When you puncture, even if you don't see any fluid coming out of the bag, the anterior capsule relaxes even without having any fluid outcome. So it means there is a gas which releases with the puncture, and you get a sufficient amount of the relaxation of the anterior capsule, and then you can start the capsular access.
Dr. RP, have you ever thought of making this tip slightly hotter before entering, so that you cause some amount of charring, which will be stronger opening?
That you can do, sir.
Hitting the tip.
So that part I will leave you, because you do all these things, no? Because that kind of machinery innovation, because I've seen you are so many innovations, very interesting innovations, because you can.
Yes, sir.
It's a good idea. I think make it hot and then puncture it. Yeah, good one.
CTS in pipeline, continuous thermal capsulotomy is pipeline, where they have added 6 mm ring of steel with this thing, which can coagulate the anterior capsules and all. So,
Dr. RP, there is one comment. Dr. Kamal Kapoor's presentation and Dr. Ramesh's presentation, the capsular thinness and thickness, what they have defined.
Yeah.
Accordingly, suppose you want to modify, rather puncturing in the center, can you think of puncturing at little periphery?
See, actually, as I told you, because that thickness does not matter actually, because the thickness is hardly there is any difference between the center and the periphery. And if at all it is thick, it is beyond 6 mm, not within the 6 mm. I'm 100% sure. So if you are puncturing beyond 6 mm, then how you make the capsular access? It's not
because Kamal Kapoor did that inverted T shape, and that was again at the periphery.
That inverted T technique is within 6 mm, sir. It's not beyond 6 mm. It's within 6 mm. And the thick anterior capsule is beyond 6 mm. It's not within 6 mm. So that concept is, because it's very good, like you make a T, then you can start the capsular access, but it has nothing to do with the thickness of the capsule.
Okay. Thank you.
Sir, actually, the problem with the Argentinian flag is that, when it has to happen, it will happen.
Yeah, it happens.
So we can very well carry on discussing like anything.
I just want to explain this point of Dr. Bali, because very nicely pointed out. He always comes with the very good points, actually, Dr. Bali. I've seen, we have been together for the last 2 years as an executive in DOS. And Dr. Bali's discussion is fantastic, always. So this
Thank you so
point
much,
is
sir.
very important because actually what happens, because why the saving needle is very important, because if you are puncturing the center, you are making a hole. Whichever technique, the rest of the technique, whether you do the T flap, you do the needle puncture aspiration or capsular access, mini capsular access, in all these cases, after all, you have to puncture the anterior capsule. And there is a threshold of pressure, because all the cases, they won't go into the Argentinian flax. And because we do 100 cases of intumescent cataract, only hardly 2 or 3, they convert into the Argentinian flax and whatever technique you use. But you have to prevent these 3 or 4 cases only, because with the capsular access, microcapsular access, and using needle, using capsular access, was using T-flap technique. If that patient has to extend, whatever you do, that will extend. And then nothing will go. So the saving needle is one of the very safest technique, because if that patient has to go into the Argentinian flax, and you can save that patient by puncturing that round puncture at the center, release some pressure, then you start the capsular access. So that is the difference actually, because if the patient has to go into the Argentinian flax, then it will go whichever technique you use, except the saving needle technique.
So the skill lies in tackling the complication.
Yeah,
Like
that's right.
after discussing all these techniques, whenever
Yeah.
it happens, I think
Then
the real surgeon is that who
yeah.
tackles the complications.
So your next session, next actually episode should focus on the complications of capsular access and how to tackle that. I think that would be a very nice one, because then doing the MSICS, manual small incision cataract surgery, if you land up with the capsular access complication, then how to handle, how to continue with the manual small incision cataract surgery in these situations should be the, I think, next episode.
I think considering all these types of capsular tackling, starting from Dr. Thorat, RP, and Dr. Ramesh Shah, and Kamal Kapoor, and Dr. Meghu, I think all these techniques were, I think, useful in SICS rather than FECO, what I should say. You had a little liberty to tackle the cortical matter and nucleus, because you have got more liberty to tackle in SICS rather than FECO. That's what I feel.
True. Very right.
What a fascinating discussion we're having, and it's been almost 2 hours that we've started, and amazing presentations by everybody. Just when you keep doing so many capsular access and think that you know capsular access, we should attend a seminar like this. So you suddenly start feeling, oh my God, there are so many things that we need to consider and learn from each other. Before we conclude the session, I would like to invite the chairmen of this particular session to give their comments before we can conclude. So we'll start with Dr. Prakash Marathe.
I think, thank you, Amir, for wonderfully comparing the session along with Dr. Pankaj. Under the guidance of Dr. Anil Shah, I think this was a successful webinar, I must say. And so many stalwarts, almost 5 presenters were there. And it was not only capsulotomy, but their technique, their videos, what we observed here, definitely will be helping juniors as well as practicing ophthalmologists. I was impressed with the presentation. Of course, it was the basic presentation by Dr. Shirish Thorat. Dr. Rajendra Prasad's technique, which was appreciated internationally also, it was fantastic technique. Not to forget Dr. Deepak Meghu's technique. Then Ramesh Shah is always innovative. And even Kamal Kapoor presented in a nice way. All these presenters, they presented.
योगेश शाह यांना बोलवा ते राहिले केसेस यांच्याला तर त्यांना बोलून घ्या.
I think all these presenters, they are stalwarts in their technology, but it was very nice to observe each and every one of them. It was their own technique, like RP's technique was unique for him, Kamal Kapoor's technique, Ramesh Shah's technique, Meghu's technique. And I think youngsters and other ophthalmologists, general ophthalmologists, SICS surgeons, they are definitely benefited by this. And this was a wonderful webinar. And this series definitely started almost one year, more than 1 year ago now. And it will be continued with newer and newer videos, and newer and newer presenters will be given the opportunity in the future. Thank you so much.
Thank you, sir. I would like to now ask Dr. Yogesh Shah, sir, if he's available to give his talk. He wants to discuss. I don't think it's available. We'll get them when he comes online. Till then, I would like to ask Dr. Mandar Paranspe sir to give his thoughts on the session.
First of all, congratulations to all the speakers, to the discussants and the moderators for an excellent webinar on one of the most important steps of modern cataract surgery. Capsulorhexis, as we know, is not easy and it can be extremely challenging. And we know the consequences of not getting the capsulorhexis right each and every time. Now we have a lot of modern tools like Dr. R.C. Shah has shown, plus we have the femto LASIK as well. But still, considering all the constraints, I think the manual technique of capsulorhexis still is important, is very vital. Everybody who does cataract surgery has to learn this step to do a successful cataract surgery. And we had some wonderful presentations by various speakers. So it was extremely enjoyable and it was a great learning experience from all of them to see those presentations. And you learn those small tips of doing these challenging cases from these presentations. So thank you to all of them. And thank you, MSICS Maharashtra chapter, for the opportunity.
I would now like to call upon Dr. Yogesh Shah.
He is not there.
I think Dr. R.C. Wants to speak before we conclude the session. Oh, okay, right. Dr. Yogesh Shah has not joined. So, Dr. Boramani, a few words and then we'll conclude the session.
I'll say very few words, only 5 words. I learned many things today.
Definitely.
Same here, sir.
When the person like Dr. Boramani says that he has learned, definitely, I think it is the height of success of the webinar, I must say.
And sir, I learned how to do a webinar. This is how you do it.
Oh, that's good. That's great.
Sir, this particular this thing goes to Dr. Anil Shah, sir. He's the one who told us that in a webinar, we need to give the speaker as much time as possible and also for the discussion, because you can't have good discussion and presentation in 7 minutes and 7.5 minutes. So I think we can do justice to all your hard work and the way you want to present. Yes, Dr. Anil Shah.
Thanks for all the speakers and the discussant who has given their time. I wanted that a capsulorhexis should be a complete topic. Anyone who wants to learn capsulorhexis, he can visit our episode 10 and episode 11 and he can get all the information which is available and he can learn capsulorhexis in a very detailed manner. Here again, I am giving one announcement that for all the presenters and all the discussion, I will be giving 5 snares complimentary from my side to everyone who has participated in this webinar. I'll send them.
How to use it?
Is this going to be available on YouTube?
Yes. This is available on the. This is
same link.
All the episodes are available on the YouTube.
All the episodes are on YouTube, sir.
We expect Capsulotomy also, sir, from you.
Sir, I think the moderators also deserve, I think, more snares.
Yes. Everyone, for everyone. Even I'll give to the previous speakers also, all the previous episodes and previous webinar also.
Sir, can we join the previous webinars?
Yes, sir. It is my pleasure, sir.
Yeah.
Thank you, sir. For your...
It is great of Dr. Anil Shah.
Yes, sir. Yes,
also generous and spreading his technology everywhere. And that snare technology is very popular because of that. And that is a real innovation, which is appreciated at all platforms in various conferences.
Thank you so much.
All of very true.
Thank you, sir.
Yeah. So in conclusion,
thank you so much, Dr.
I would like
Brahmani.
to thank all our speakers, Dr.
Anil, thank you very much.
Thank you, sir.
Yeah. And all our discussants for a wonderful webinar. And I thank Entod for making this possible. Thank you and a very good night to each and every one of you.
Good night.
Thank you so much.
Thank you.
Good night.
Bye. Good night.
Thank you, sir.
And his entire team.
Sir, thank you very much, sir.
Good night, sir. Dr. Shah, good night.
Thank you.
Good night.
Fantastic. Good night, Dr. Rahman.
Yes, Dr. Jatinder Wali, thank you very much.
Right, sir.
Okay, Mr. Jain, you can close it now.
Rahul, if you want, you can.
राहुलचे काही थॉट्स घ्यायचे आहेत का राहुल बोल
Rahul, if he wants to show his product and his video.
राहुल झोपला
Rahul is muted, I think.
सर सर